today's AARC approved course, Introduction to Biphasic Cuirass Ventilation. My name is Shane Torrios and I will be your instructor today. I'm a practicing registered respiratory therapist for the past 10 years and have experience in the acute, long-term acute, and home care setting. I have worked with this product for the past 5 years in my professional career, and I'm currently serving as the clinical educator for the company sponsoring this course, Hayek Medical Devices, a United Hayek company. The objectives for this course include to understand the basic concepts of biphasic cuirass ventilation, or otherwise known as BCV, to be mindful of the considerations prior to initiation, how to properly initiate and apply BCV to your patient, how to choose the appropriate settings for your patient, and lastly, how to set the alarms and general considerations to be mindful of while using BCV. First, let's go back to the basics of our normal anatomy and physiology. Respiration consists of two phases, an inspiratory phase and an expiratory phase. During inhalation, the diaphragm and intercostal muscles contract. The diaphragm moves downward while the intercostal muscles pull the ribs up, expanding the thoracic cavity, increasing thoracic dimension. The resulting decrease in alveolar pressure below atmospheric pressure causes airflow and lung inflation. During exhalation, the diaphragm and intercostal muscles relax, and exhalation occurs as the chest returns to its pre-inspiratory volume, pushing air out. During cardiopulmonary illness, exhalation becomes more active. Accessory muscles of exhalation are utilized to force gas out and thereby increasing minute ventilation and energy consumption. This is why various negative pressure ventilators were tested in the past. They saw how negative pressure breathing facilitates normal functions of the lung. According to Boyle's law, during inhalation, more volume results in decreased negative pressure. During exhalation, the increase in pressure results in decreased volume in the lungs. As useful as negative pressure ventilation was in the past during the polio epidemic to save countless lives, there were disadvantages to the iron lung. It was cumbersome, so it was large and bulky. Clinicians had limited access to patients. Cardiac complications included reduced venous return, increased afterload. It also exacerbated pulmonary edema and pitting edema, which then led to venous pulling in the extremities. Another drawback was that a clinician was unable to increase pressures or frequencies for their patient. As time progressed, negative pressure ventilators with a Cuirass shell were developed with something as small as what is pictured powering it. Previous Cuirass ventilators operated on negative pressure ventilation. However, it relied on a sigh breath to allow for passive recoil of the chest. Ultimately, it was intermittent negative pressure ventilation. Though it worked wonderfully for the ideal patient with normal and compliant lungs, it wasn't sufficient for those that had compromised lungs. They were unable to get enough tidal volume or minute ventilation, and the technology did not allow for higher pressures or frequencies, as it still relied on passive recoil by the patient. Which brings us to our topic at hand, biphasic cuirass ventilation. Biphasic refers to its ability to have full control of both phases of our respiration. Cuirass references the armor soldiers use to protect the organs below their thoracic cavity during battle. Ventilation, as it promotes just that, effective gas exchange. BCV controls both phases of the respiratory cycle. During the inspiratory phase, BCV uses the power of negative pressure to inflate the lungs through a Cuirass shell. Unlike previous Cuirass ventilators, we do not rely on passive recoil of the chest. The technology allows for an active expiratory phase. As a result, BCV counters the previous drawbacks of negative pressure ventilation. The active expiratory phase allows us, as the clinicians, to control the patient's minute ventilation and maintain an adequate tidal volume. As we have already noted, natural and normal is always better. It ventilates in sympathy with our natural breathing cycle, which lends itself to the natural benefits of spontaneous breathing on heart function. As a result, it removes the risk associated with positive pressure ventilation either by using it as a standalone device or by countering the common risks associated with positive pressure ventilation by using it in conjunction with it. As noted on the diagram, we have the ability to improve the patient's quality of life by providing them with something non-invasive. It allows them the dignity of making decisions about their own care, as well as to eat, drink, and speak. There are various articles that prove that as a result of using BCV, it has decreased mortality rate for various disease processes. BCV offers 3 basic support modes and a separate timed airway treatment mode. The secretion clearance provides both high-frequency chest wall oscillation for thinning and mobilizing secretions, then cycles into an assist cough mode, which provides a very potent means of enhancing expectoration. The Hayek RTX Cuirass ventilator is a negative pressure, pressure-targeted, timer pressure-cycled, non-invasive ventilator that creates intrathoracic pressure changes similar to natural respiration. Utilizing a Cuirass shell that connects to the ventilator with wide-bore tubing and a pressure monitoring tube, the Cuirass creates an extrathoracic air chamber over the chest wall, allowing negative pressure support of ventilation to occur. The Cuirass shell creates an air chamber over the chest and abdomen, while the RTX controls the pressure within the Cuirass. The pressure affects the dimensions of the thoracic cavity and thus inflation and deflation of the lungs. Inhalation occurs due to the RTX creating a negative pressure within the Cuirass. The RTX supports inspiration with the natural expansion of the chest wall and descent of the diaphragm. In modes that provide ventilation, the RTX ventilator alternates the Cuirass pressure from negative to positive. This active positive expiratory phase creates a compression effect on the thorax, facilitating lung deflation. Our next objective is the practical application of biphasic Cuirass ventilation. We will be referencing the training tool entitled Application of the Hayek RTX. Majority of our discussion will be based on this booklet, so I've copied the link available to download in the chat box. On page 1, you will see at the top the partial list of indications, which include acute respiratory failure, neuromuscular disease processes, bronchiectasis, cystic fibrosis, asthma, atelectasis, and many more. There are a few considerations and contraindications to be mindful of. Burned skin and draining wounds may be exacerbated. Those that weigh more than 180 kilograms, as the negative pressure may be affecting adipose tissue as opposed to ventilation. With scoliosis, if you are unable to obtain a good seal, another therapeutic option may need to be considered. And lastly, lack of a patent airway. Once we have determined that the patient in question is indicated for use of BCV and all considerations have been accounted for, we now need to choose the correct Cuirass shell size for the patient. We have 12 different shell sizes available, ranging from a neonate to an adult. Here you will find 2 primary ways we would be able to determine the correct shell size, either by their weight in kilograms or by measuring their torso. Measurements from their torso lengthwise should be from sternal notch to just below the umbilicus, and the measurements widthwise should be from mid-axillary to mid-axillary. Going back to the size grid, let's say, for example, we needed to size a patient that weighs 50 kilograms according to their chart. What size would they land on? Are you able to spot the size? According to the table on the left, the patient would land between a size 7, a size 8, or a size 8B. How would we then narrow down the size? Carefully consider the patient's size and shape when fitting. Select the largest Cuirass size that will ensure a good seal for the greatest therapeutic effect. More than one size will fit most patients. Adjustment to a larger or smaller size may make a difference. It is preferable that the Cuirass length measurement slightly exceed the vertical measurement of the patient. Horizontal Cuirass measurement can vary slightly from patient width without affecting performance. If it is too narrow, it has the potential to add restriction. However, please also note that these are initial guides to choosing the correct shell size. The more that you, as a clinician, utilize BCV, the more skillful you will become in selecting the correct shell size by sight alone. You would be able to hold the Cuirass shell to the patient's chest and determine which shell size would work best for them. Now that we've gathered the appropriate Cuirass shell size, we now need the following material: blue Cuirass pressure sensor tubing, clear airway pressure sensor tubing. This is if monitoring for apnea or utilizing the synchronized mode. Widebore tubing, a corresponding seal size to the Cuirass shell size. So say, for example, you happen to have a size 8 shell that you need a seal for. Make sure you look for the sticker that identifies the size 8 seal size. And lastly, Cuirass straps. If utilizing sizes 0 through 3, you'll also need a pediatric adapter or pediatric widebore tubing instead of the regular widebore tubing. Now we come to seemingly the most challenging part of putting the Cuirass together: applying the seal. We've worked with many respiratory therapists, and it seems applying the seal has been noted to not be as easy as it seems. Step 1. When fitting the seal to the Cuirass shell, place the seal's joint seam at the center top of the Cuirass. Cuirass should be upright facing away from you. The size of the seal with double padding should be proximal to you. Locate the inner flap on the distal side of the seal. This circumvents the outside of the Cuirass. Starting from the center top ridge, begin to attach the seal to the top groove. When the seal fits the top groove, turn the Cuirass upside down. Position the seal between the Cuirass and solid surface to hold it in place. Step 3. Starting from below, gently stretch and ease the seal's inner flap into position on the right and left side of the Cuirass. Gently fit the remainder of the seal to the corner and the bottom ridge edge of the Cuirass. Once the seal attaches around the sides of the plastic, adjust it so that the lip of the seal fully covers the ridge all the way around to ensure the best possible seal. Now let's attach our blue pressure sensor tubing to the port right below the letter Y of Hayek and the widebore tubing right above the Y of Hayek. Once we've secured the seal onto the shell and attached the appropriate tubing to the shell, we shall now turn the machine on. On the lower right corner of the right side of the machine is a black toggle power switch. Press to power on. Unit will complete an initial self-test before starting in same mode with all settings preserved from its use. Please note that during the unit self-test, you need to ensure that all the tubing is disconnected from the machine to ensure it calibrates to ambient air pressure. Before anything else, there is a default apnea alarm that appears with each new power-up. If you notice the screen on the far right-hand side, the alarms are positioned vertically. There are 3 colors for that alarm screen: blue, meaning that it's an inactive alarm; green, meaning it is an active alarm; and red, meaning that alarm is currently being triggered. In this instance, it is because it is sensing 0 activity in the airway graph for the past 20 seconds, triggering this apnea alarm. Please also note that the alarm notice at the top right-hand side of the screen, when there is an alarm being triggered, will read "alarms muted" and the light near the connection port starts flashing. This alarm will need to be turned off or set to 0 until it is needed for apnea monitoring or the airway sensor modes. To turn off the alarm, we will need to press Menu using the arrow buttons, scroll to Alarm Settings, and press the Accept button. From there, we will use the arrow down button to navigate right next to apnea duration and use our number keypad to input 00 to replace the number 20 to 0. You will then need to press Accept to accept the changes that were made. Now we will finally connect our widebore tubing to the front of the ventilator and blue pressure sensor tube to the Cuirass sensor port. If you notice the 2 horizontal graphs on the screen, one is labeled Cuirass and the other is labeled Airway. If we did have the airway sensor tubing connected to the airway sensing port, you would see activity on that graph and the corresponding numeric values to the left of the graph. However, for the time being, we'll focus on the graph labeled Cuirass, which corresponds to the blue Cuirass sensor tube connected to the connection port and to the shell. The activity on that graph and numeric values measured will correspond to the pressures within the Cuirass shell. Since it is not yet turned on, everything should read 0. Before leaving the screen, let me point out the other elements. Current mode will be located on the upper left-hand corner. The current settings are set at the bottom. The actual monitored values will be listed on the left-hand side of the machine. And last, the top of the screen will either be blue and read standby or will be green and read on. Note, if attempting to start the machine and it is not yet green, stating it is on, you may need to press it again with a lighter touch, as the keypad is sensitive. Now that we have put the machine together, let's apply it to our patient. Regardless of what mode we'll be using for our patients, whether it's control or secretion clearance, when applying the Cuirass to our patients, we must always first apply continuous negative to ensure a natural form-fitting seal, even before applying the Cuirass straps. In order to apply continuous negative, we will need to do the following. First, check the current mode. What mode are you on? Are you on continuous negative? If yes, check the setting. If it is set between -10 to -15, no changes need to be made. However, if you're on another mode, let's navigate to continuous negative. First, press menu and use the arrow up button to scroll to mode selection. Press accept. Now use the arrows to navigate to continuous negative and press accept. Now we'll input the value between -10 to -15 and press accept twice. Note, every time you see the orange screen on the right-hand side, that is the alarm screen. If no alarms are to be set, press accept again and you will then return to the main screen. Once you do a quick check, current mode is continuous negative, and the setting below reflects the setting that you set. You are ready to apply the shell to the patient. Place the straps below the patient if they are in the supine position before turning the machine on. Also, before applying the Cuirass shell to the patient, please ensure that there is a cloth or clothing barrier between the foam seal and the skin. Also, please note position of leads, lines, tubes, or drains that will be within the Cuirass shell, and plan position of the Cuirass so the seal will not pass over any points of entry for either of those leads, lines, tubes, or drains. Now, if there are lines crossing under the seal, padding between the line and their skin will ensure the patient's skin is protected from any pressure ridges. Once all of the safety checks are done, pull the sides of the Cuirass open and place over the patient's chest and abdomen. Flex and advance downward on the chest until contact with sternum and abdomen is achieved. If there is a space between the foam seal and the patient's chest, the Cuirass shell will not be able to pressurize properly, and an Error 21 or low pressure alarm will occur. When ready to start therapy, press Start, Stop to begin pressure delivery. As a reminder, top center of the screen should change from standby to on, highlighted in green. If that change does not occur, you may need to press it again with a lighter touch as the keypad is sensitive. You will note that the actual monitoring values on the left-hand side for the Cuirass graph now reflects the values set, meaning the inspiratory pressure, if set at -15, now reflects between -14.5 and -15.5. It is now safe to secure the straps in place. Ensure the straps are not twisted in the back. They can be applied straight across or crossed in the back, whichever is most effective for the patient. Pull the straps snug so that they will not allow the Cuirass to move around on the patient's chest when ventilating. As a safety check, run your hand around the foam seal to ensure that there are no leaks. To navigate to the desired mode, please follow the step-by-step procedure highlighted on page 6 of your booklet. Continuous negative does exactly what it sounds like. It's a constant negative pressure generated extrathoracically within the Cuirass shell. Physiological effects include increases the functional residual capacity by creating a continuous negative extrathoracic pressure while the patient is breathing spontaneously. Alveolar recruitment, small airway dilation, increased alveolar capillary perfusion, decreased work of breathing, improvements in ventilation and perfusion matching, and it also enables more effective spontaneous ventilation. Precautions and considerations include patients must have an adequate respiratory drive. It also works well for most early hypoxemic and hypercarbic respiratory failure. CNAP can be used to augment positive pressure ventilation to counter risks associated with high PEEP pressures. However, when CNAP is reached, you may notice an increase in mean airway pressure on positive pressure ventilation. In order to resolve that, you will need to begin to decrease PEEP. Starting settings are as stated on the slide on the right-hand side. Adults is -8 to -15, pediatric -6 to -10, and infant is -4 to -8. However, if the patient is experiencing increased work of breathing, hypoxemia, or extreme alveolar recruitment needs, the manufacturer recommends that the settings be placed -20 or more negative. Please note on the screenshot of the screen the following numeric values within the Cuirass shell that are being measured. The inspiratory pressure is -20.3, expiratory pressure is -19.7, and the mean is -20. Since only one value was set for continuous negative, the mean or average pressures are consistent for all three values. This will only occur for continuous negative mode. Later on, for the other biphasic modalities, you will see that those values will vary depending on the inspiratory and expiratory pressure set, especially the mean Cuirass pressure, or mean. This is important, as this value would be relevant to the end expiratory volume left in our lungs. Now in the algorithm, if we see improvement in the patient, we can now titrate the pressures to lower numerical values per clinical response and hopefully wean them off BCV completely. However, if there is no improvement, despite incrementally titrating the pressures to higher numerical values or more negative pressures, and especially if the patient is starting to clinically decline, we will most likely need to advance to control mode. Control mode is the first biphasic modality that we will consider. This mode has a set frequency, inspiratory pressure, expiratory pressure, and IE ratio. It would be equivalent to intermittent mandatory ventilation, or IMV mode. Indications would be a weak or absent respiratory drive, CO2 retention and/or dyspnea unresponsive to CNAP titration. It could also be used with positive pressure ventilation in assisting mode with a greater BCV rate than the patient's total respiratory rate, in order for BCV to be the driving ventilator. The physiological effects of this mode on the body include that it controls both inspiratory and expiratory phases while providing full control for rate and breath timing of supported breaths. Increased minute volume, supports spontaneous breathing, capable of full support of ventilation, alveolar recruitment, small airway dilation, increased alveolar capillary perfusion, decreased work of breathing, and improvements in ventilation and perfusion matching. Now, let's take a look at the precautions and considerations. Number 1 reads, mean Cuirass pressure should always be kept more negative than -4. Remember we noted that mean Cuirass pressure value was relevant to the end expiratory volume in the lungs? Just like our natural anatomy and physiology, even at the end of expiration, we always have a functional residual capacity, or end expiratory volume, left in the lungs in order to prevent them from collapsing. By maintaining at least -4 or more negative mean Cuirass pressure, we are also able to maintain that FRC, or end expiratory volume, in the lungs. How can that be achieved? There are 3 principles that'll help us to achieve this. Number 1, at rates greater than 60, inspiratory and expiratory pressure should balance. For example, -15, +15. Number 2, delta P or change of pressure should exceed 10 centimeters of water pressure. And number 3, maintain pressure ratio at or near 3:1. For example, let's take a look at our starting settings. An adult is recommended to start at -21 +7, pediatric -18 +6, and an infant -12 +4. Do you see a trend? They all maintain a balance of the 3:1 ratio. The value 21 is 3 times the value of 7, same with 18 and 6. Now, let's take those values, shall we, and refer back to the second principle. Delta P, or change of pressure, should exceed 10 centimeters of water pressure. What is the delta P, or change of pressure, for -21 and +7? Since we are using a negative and positive number line with 0 in the middle, if we count -21 to 0 and 0 to 7, the value would be 28. It follows the principle of being a value greater than 10. Why is this important? Remember, these principles help us to maintain a mean Cuirass pressure of at least -4 or more negative. Now, let's take a look at the screenshot for control mode for a moment. At the bottom, we see a set frequency or rate for 20, inspiratory pressure at -21, expiratory pressure at +7, and an IE ratio of 1:1. Now, let's look at the actual monitoring values on the Cuirass graph. It reads -21.3, +7.2, and a mean Cuirass pressure of -5.9 and a frequency of 20. This indicates that the Cuirass has a good seal and is working well. Now, let's say, for example, that we did an ABG on this patient that was currently on these settings. And we noted on the ABG that they were experiencing hypoxemia. How would we adjust our therapy to assist them? We could add supplemental oxygen, such as a high-flow nasal cannula, or adjust the settings. How so? Let's take a look at the algorithm. It reads that for hypoxemia, that we need to make the mean Cuirass pressure more negative. So if they had a mean Cuirass pressure of -5.9, we may increase our inspiratory pressure to -24, +7, or -25, +7. We said that we had to at least have a balance of 3:1. However, we could also adjust the ratio from 4:1 or 5:1 to increase the end expiratory volume in their lungs. It'll drive down that mean Cuirass pressure. Now, what if the patient's ABG reflected that they were borderline hypercarbic? How would we adjust the settings? Let's take a look again at the algorithm. It says higher minute ventilation. So either we could increase frequency or respiratory rate, or increase values for both inspiratory and expiratory pressure. If they were set at -21, +7, we may increase them to -24, +8, or -27, +9. Respiratory synchronized works similarly to pressure support as patient's inspiratory effort initiates negative inspiratory support phase, and end of inspiration, beginning of exhalation, initiates the expiratory support phase. Also, patient effort determines depth and timing with each spontaneous respiratory cycle supported. This mode allows for full synchronization with patient's own respiratory pattern via airway triggering or Cuirass triggering. The patient has full control of their frequency and IE ratio. Inspiratory pressure and expiratory pressure is set according to the principles we discussed for control mode, with a balance ratio of about 3:1 and a delta P or change of pressure of at least 10 centimeters of water pressure. If apnea occurs, RTX defaults into the backup rate at set pressures. Airway triggering can be achieved by either putting the airway pressure sensor tube in a nasal cannula and place it in the patient's nostril or mouth. Another way is to tape the sensor tube inside a tracheostomy mask and place it over the tracheostomy. Or you could use a standard type T airway adapter with pressure sensing port connected directly to the tracheostomy or endotracheal tube. Pressure waves on graphic display must be visible to assure reliable and consistent triggering, as demonstrated in the screenshot image on the slide. Airway trigger is more sensitive. Starting sensitivity should be set at 5 and adjusted for maximum synchronization. Cuirass triggering, on the other hand, is better for extreme respiratory effort and should be started around a sensitivity of 3. Trigger percentage readings should read between 85 to 99%, and sensitivity should be adjusted to achieve this. So say, for example, you had less than 85%. You may need to increase the sensitivity. So if you're at 5, you may need to increase it by going down to 4. Now, prolonged periods of trigger percentages of 100% may indicate auto-triggering. So you may need to decrease the sensitivity. So if you're set at 5, you may need to go up to 6. The minimum backup rate is 6 per minute, and the maximum backup rate is 60 per minute. Set backup rate to half of what patient is breathing after settle on support, usually as a safety net for apnea or hypoventilation. The shallower the patient's breathing, the more sensitive the trigger should be to capture their respiratory effort. Secretion clearance is used as a chest physiotherapy tool to enhance clearance of secretions. The vibration phase creates a high-frequency oscillatory wave to loosen, thin, and mobilize retained pulmonary secretions. Frequencies may be varied for maximum effect. vibration is followed by a cough cycle that produces the key elements of a good cough. A deep inspiration followed by a high-flow expiratory maneuver. Indications. Retained secretions from all etiologies, including but not limited to cystic fibrosis, bronchitis, secretion-related atelectasis, bronchiectasis, asthma-related secretion retention, and neuromuscular illness with a weak or non-effective cough. For high-frequency chest wall oscillation, a pressure and a frequency may be set. The recommended pressure for an adult would range from -20 to -40. The recommended frequency for an adult would be between 600 to 800 cycles per minute for therapeutic effectiveness. The frequency is measured in cycles per minute. If you may be used to a frequency read in hertz, the conversion factor from hertz to cycles per minute is 60. Therefore, 12 hertz would be equivalent to 720 cycles per minute, which would fall within the recommended therapeutic range. For thick secretions or severe atelectasis, the manufacturer recommends a lower vibration frequency. For the cough phase, the RTX supports the components of an effective cough. Start on a rate of around 20 to 40 cycles per minute, more if the patient prefers or if better effect. 24 cycles per minute is generally recommended for alert patients because it allows good rate and predictability. As long as settings or alarms are not displayed on the right of the screen, the graph should display each cough in the same position in the sweep as per the prior coughs. Patients can then be coached to huff or use whatever cough effort they have and coordinate with the positive phase for greatest effectiveness. Use inverse ratio of about 4:1 to up to 6:1. A whole cycle is considered one vibration cycle followed by one cough cycle. Set repeat count to create desired length of treatment. For example, a 6-minute cycle repeated 5 times yields a 30-minute secretion clearance treatment session. 20 to 40 minutes is total recommended treatment time. For patients on a high level of ventilation support or with high minute volume requirements, shorter periods of oscillation and longer periods of assisted cough better supports higher CO2 clearance needs. Lastly, please note that the device will go to standby at the end of the time treatment period. If the patient requires ongoing support, therapy needs to be reinitiated manually. With unstable airways, OSA, and other forms of soft tissue upper airway obstruction, negative pressure has the potential to exacerbate that obstruction. The manufacturer advises stenting the airway with CPAP or other airway adjuncts to maintain airway patency. Secretion clearance has also been shown to mobilize large volumes of pulmonary secretions to the upper airway. Therefore, it may be wise to have suction readily available. As noted earlier and as seen in the picture, patients are able to eat, drink, and speak while using the Cuirass. Also, with those that have a G or J tube in place, as long as it is located within the Cuirass shell, they are still able to utilize BCV. However, if patient is using secretion clearance, it should always precede meals and or bolus feeds. Now, if the patient has continuous feedings, those feedings should be paused when initiating the secretion clearance treatment. The Cuirass should never be applied to exposed skin. The manufacturer recommends that a cloth barrier should be used, whether it's a shirt, blanket, or hospital gown. The seal integrity should be monitored as well. If foam is starting to break down, it is advised to replace it with a new seal. As with any respiratory device, the patient's skin should be checked regularly. Please remember that we, as clinicians, were never trained to use negative pressure ventilation, let alone biphasic Cuirass ventilation. With that being said, as with anything, practice makes perfect. The more use equals more effective and smoother application. Until that point is reached, don't be discouraged. Please feel free to contact your local representative as often as needed to ensure your level of comfort in using the Hayek RTX. In addition to the application booklet, we also have the following training tools available. Number 1 is a BCV pocket guide. Number 2, a BCV quick start guide. Number 3, an advanced algorithm. Number 4, a competency test and checkoff. Number 5 is BCV frequently asked questions. And number 6 is documentation flowsheet example. The greatest opportunity to make the most difference with BCV results from early application as a first-line therapeutic intervention. Before more complex, less comfortable, or more invasive respiratory therapies, why not try biphasic Cuirass ventilation first? You may not have to do anything second. BCV is truly an amazing clinical tool that has helped many around the world to avoid a tracheostomy in the acute and critical care setting and for those in the home care setting. BCV is able to do what negative pressure ventilation wasn't able to accomplish then, and also avoid the risks associated with positive pressure ventilation. So let us do our due diligence as medical professionals to provide the best possible care for our patients. As clinicians, we dare ask ourselves, how would you like to be ventilated?